1 and we are live.
Good morning, everyone. Today we have a topic, a discussion on vertigo, and we are fortunate that we have a faculty with us. Let me share my screen. Why we have selected topic vertigo? Just give me a moment. So dizziness and vertigo demystified is the topic today. Dizziness isn't practically an imprecise term that can refer to a sense of disorientation in space, vertigo, or lightheadedness. It can also refer to disequilibrium or a non-specific feeling such as giddiness. Vertigo is a condition where a person has the sensation of movement or of surrounding objects moving when they're actually not. Often it feels like a spinning or swaying movement, and this may be associated with nausea, vomiting, sweating, or difficulty in walking. It is typically worse when the head is moved. Vertigo is the most common type of dizziness experienced in our practice. Syncope, which is totally different entity, also known as fainting, is actually different. So many times for a patient, it becomes chakkar ka routine chakkar, where they are referred from orthopedist to consultant physician, neurologist, ENT surgeon, psychiatrist, and a lot of other factors play in. As there is no specific test and diagnosis is usually by exclusion. So let us learn from our faculty members the exact thing we have to do, what protocols we have to follow, and how to diagnose vertigo. I welcome Dr. Sangeet Gawhale, who is a consultant orthopedic surgeon at Saifi Hospital, Jaslok and Bharti Hospital, Mumbai. And he has special interest in complex trauma and joint. He will be moderating the session today. We are having our patron as Dr. Wasudeo Gadegone, the vibrant, dynamic MOA president. We'll be fortunate that we'll be having Dr. Tanna sir as expert faculty. He is a beloved teacher to all of us. We welcome Dr. Tanna sir. We welcome Dr. Sangeet Gawhale. We welcome Dr. Jay Deshmukh. He is a senior consultant physician at Sunflower Hospital, Nagpur, and has various roles of chairman of ethics committee. He has many awards of professional excellence to his credit, and an excellent physician. He is regularly writing for health archives for public health education. We welcome Dr. Madan Kapre, who is director of Niti Clinics, has Lifetime Achievement Award of FHNO, and is a national president, Foundation of Head and Neck Oncology. We welcome Dr. Vishal Kundanani. He is the chief spine surgeon and head clinical services, Lilavati Hospital and Breach Candy Hospital, Mumbai, and has special interest in microendoscopic minimally invasive spine surgery, craniovertebral CV junction spine surgery, navigation assisted spine surgeries, scoliosis, and spinal deformity corrections. Welcome, Dr. Vishal. Harshwardhan Jain is the radiologist, consultant radiologist at Nagpur. He had special training in cardiac imaging and the musculoskeletal imaging as well. Dr. Dhruv Batra would be guiding us the neurologist perspective, and he has a lot of experience and publications in field, and he'll be guiding us about the neurophysician's perspective onto the management of vertigo. So let us welcome all of our faculty members, and I invite Dr. Jay Deshmukh to please start his lecture on physician's perspective in managing vertigo. Welcome, Sangeet. Sangeet, you please have your own initial.
Yeah. Can we start?
Yeah.
Okay. Hello.
Yeah, I can hear you, sir. We can see your screen also.
Yeah. So good morning to all of you, and thank you Orthopaedic Society and Dr. Chandak in particular for giving me an opportunity to speak on this wonderful forum. As a physician, I'll tell you what my perspective would be when it comes to vertigo. And this really takes me back almost about 20-25 years back, when I saw a person who said that whenever I used to pick up flowers, or whenever I used to stand up and pull out something down, I used to feel very giddy or dizziness or blackouts. When I investigated her, in a short period of time, I found that she had a big left atrial myxoma. And this really kindled my interest in finding out how early we can sort of come to a conclusion in patients who have had vertigo or dizziness or giddiness or presyncope, which have much of overlap like symptoms. So as Dr. Chandak has already said, that vertigo in fact denotes a hallucinatory sensation. And it is just a symptom, it is not a disease as such, which is caused by a mismatch of information. Now, for a proper balancing, we need to have proper inputs from the vestibular system, visual system, and the posterior columns of the body, that is the proprioceptive system. And therefore, you could have a peripheral vertigo, an intermediate vertigo, or a central vertigo. Vertigo, therefore, can be caused by lesions in any of the following systems, except peripheral, which could result as a result of disordered generation of nerve impulses by the vestibule. And you have intermediate vertigo, wherein there is faulty transmission of impulses along the 8th cranial nerve, or the central, where there is misinterpretation of impulses by vestibular nuclei in the brain. The causes of peripheral, intermediate, and central vertigo are very many, like a benign positional vertigo, Meniere's disease, labyrinthitis, vestibular paroxysmia, and so on in patients who have peripheral vertigo. In this benign positional vertigo, Meniere's disease and labyrinthitis are pretty common. In the intermediate form of vertigo, vestibular neuritis and acoustic neuroma are also seen. Acoustic neuroma is one important diagnosis which one should not miss when a patient presents to you with vertigo, because the implications are far too many if it is diagnosed late. And absence of the corneal reflex is the first sign, I could say, of acoustic neuroma. Drugs which can be ototoxic can also cause vertigo, which belong to the aminoglycoside group like streptomycin and so on. In the central cause of vertigo, vertebrobasilar insufficiency stands out as it is most common. And we need to look at vertebrobasilar insufficiency rather very seriously and critically, because unless treated early enough, your patient can land up with a very complicated stroke. Multiple sclerosis, some neurodegenerative disorders, migraine, brain tumors, and epilepsy are also causes of central vertigo. The direction of nystagmus, visual fixation, the severity of vertigo, direction of fall, and presence or absence of tinnitus or deafness can really tell you whether it is a peripheral or a central vertigo. So first of all, whenever you have a patient of vertigo, you need to ask yourself whether I'm dealing with the peripheral part of vertigo or whether I'm dealing with a central diagnosis of vertigo. And in this way, by this clinical sort of approach, which has been mentioned over here, let's say visual fixation, it inhibits vertigo and nystagmus if it is peripheral. Then the direction of spin is towards fast phase in a peripheral vertigo. And the duration of symptoms in the peripheral vertigo are recurrent, but they are rather very chronic in a central part of vertigo. So I think these are simple bedside symptoms and signs which you can really do and find out whether the patient has a peripheral vertigo or central vertigo. Now, when you have a patient of vertigo, what type of physical examination is expected? Just see if there is a foreign body or a wax in the external aortic canal. Look for otitis media, auscultate for carotid bruit. Blood pressure in supine and standing position is extremely important. Look for any perforation of the tympanic membrane. Blood pressure in both the upper limbs, right and left, and pulsations is extremely important. You may have Takayu's disease, and that can cause sometimes central type of vertigo. Nystagmus, patient's hearing, fundus examination, external auditory canal vesicles, like you may have a Herpes Zoster or a generic ganglia, and that is known as Ramsay-Hunt syndrome, and so on. So these things are pretty common in clinical practice when it comes from a physician's perspective point of view. Now, these are the various characteristics of central and peripheral vertigo, which I have already enumerated to you. But as far as the diagnosis is concerned, I would rather like you to consider on the right-hand side, when if you have a CNS infection, tumor in the posterior cranial fossa, cerebellar infarcts and cerebellar hemorrhages can trigger off vertigo. They may present to you for the first time with vertigo, vomiting, loss of balance. Then anterior and posterior inferior cerebellar artery syndromes, multiple sclerosis, though rare in India, but we see as physician 2-3 patients per year. Basilar artery migraine, or a vestibular migraine, rather very common. Hypothyroidism, very important cause for vertigo if not diagnosed. Hypoglycemia, hyperglycemia, and certain paraproteinemias. Labyrinthine disorders would obviously be covered up by the ENT surgeon. And if I go to the case number 1, a 65-year-old female presented to the hospital with sudden onset of vertigo. She had headache, vomiting, swaying, blurred vision, and diplopia. Now, when you see a diplopia or vomiting or swaying of gait, blurring of vision, it means that straight away the cause goes to the central type of vertigo and not a peripheral. In addition, there has been a deviation of mouth, cerebellar signs were present, and left frontal was extensor. MRI showed a hemorrhage in the posterior cranial fossa in the cerebellum, and as you know, that this is one type of hemorrhage wherein the neurosurgeon should be involved and the cerebellum should be taken off. A 60-year-old male had a sudden onset of vertigo associated symptom, again, left hemiparesis and other issues along with that. So that means, again, this person would have a central type of vertigo and MRI brain showed a pontine infarct. So again, it's very important to understand whether you are dealing with a central part of vertigo or a peripheral part of vertigo. The brainstem or cerebellar ischemia or infarction can cause various types of vertigos. Important to understand is whether the patient has diplopia or numbness of the face. And remember that whenever you have a posterior cranial fossa lesion, CT scans are not all that very sensitive and specific. MRI of the brain is extremely important to diagnose posterior cranial fossa lesions. All brainstem or cerebellar ischemia infarction syndromes are associated by other neurological symptoms and signs. Basilar artery or vertebral-basilar artery insufficiency is common. You won't expect this in a person who is 20 years old or 25 years old. But certainly, if a 60, 70, 80-year-old man, and these patients are very common in orthopedic practice because of spinal fractures, fracture neck femurs, and so on. When they have giddiness, you are going to think more of vertebral-basilar insufficiency than a peripheral cause of vertigo. And remember that these patients need to be on antiplatelets, anticoagulations, and possibly thrombolysis. The diagnosis of choice or the therapeutic investigation of choice would be an MRI of the brain with an MRA, that is magnetic resonance angiogram. Now, although this disease, that VBI, should always be in the differential diagnosis, if you have recurrent forms of vertigos which are not accompanied by other neurological signs, and this may suggest another disorder altogether. But however, if you have a TIA, transient ischemic episode, in the anterior territory versus in the posterior territory, and when the posterior territory ones are associated with vertigo, remember that those with vertebral-basilar insufficiency are likely to progress to stroke more quickly than those in the anterior territory. And therefore, this is a red flag warning to all of us that if you have vertebral-basilar insufficiency, treat the causes like hypertension, diabetes, dyslipidemia, quitting smoking, tobacco. Make sure that blood pressure is brought under control, and these patients are put on antiplatelet agents or antithrombotic agents, as the case may be. Multiple sclerosis may present for the first time with vertigo. And remember, a young female patient coming to you with giddiness, vertigo all the time, and getting better in between, again coming and has some recurrent symptoms going up and down. Think of multiple sclerosis, and though it is uncommon, I believe that most of the patients of multiple sclerosis in our country are missed. It's important to diagnose multiple sclerosis early enough, because otherwise it will be too late, and most of these patients may later on become wheelchair-ridden. If you look at this patient of mine, 3 years old, the patient has had vertigo, which has been increasing for the last 1 year. And this is something which we should never miss. The patient had had imbalance and swaying on walking for 3 years, which has further increased in the last 1 year. There's some neck pain, which increases on bending forward. There is some nystagmus. Reflexes are normal, but cerebellar signs are positive. So again, vertigo, pain in the neck, cerebellar signs, and then MRI showed a Chiari malformation, Arnold Chiari malformation. Sometimes syringomyelia, syringobulbia, and all these things can present with giddiness or vertigo as a clinical or the first manifestation. So posterior fossa structural abnormalities also should always be thought of in patients who have vertigo. Many times patients come walking to you and tell you that, well, doctor, I'm having vertigo, what do you do? This and that. But just ask them to do tandem walking, or that means walking on the straight line, one step behind the other, and they may sway here and there, and then make sure that you immediately get the MRI done and particularly of the basal skull as well, and you will never miss the diagnosis. Now, interestingly enough, there are some patients with benign recurrent vertigo who also have auditory symptoms similar to patients with Meniere's disease, and a mild hearing loss also may be seen on audiogram. The key distinguishing feature between migraine and Meniere's disease is the lack of progressive unilateral hearing loss in patients with migraine. Migraine is again a very common cause for vertigo, particularly basilar artery migraine or a vestibular migraine. These patients would have telltale evidences of triggering factors like lack of sleep, exposure to heat, travel sickness, then around menses, then when they hear a lot of high decibel sounds and traveling and so on. And this is typical of vestibular migraine when they have associated significant vertigo. You examine them clinically, they all appear to be normal. You do the MRI or any imaging technique, they're all normal. And these patients would get better only with specific anti-migraine treatment in form of, say, preventive therapy like doxycycline or beta blockers or verapamil. And the exact treatment would be obviously, the vasopressin, as you mentioned, or the various triptans. The diagnosis of migraine, vestibular migraine or basilar artery migraine, should be entertained in any patient who has chronic recurrent attacks of dizziness of unknown cause. Though the diagnosis of migraine-associated dizziness remains one of exclusion, little else can cause recurrent episodes without any other symptom over a long period of time. So if the patient says they're having vertigo giddiness for the last 2-3 years, you examine the patient details, nothing is there, MRI CT is normal, other metabolic factors ruled out, a patient who is relatively young, well, this patient will be having migraine. Now, this particular patient was 28-year-old who had had some brain surgery 3 years back. No records were available. There was no nystagmus, bilateral symmetrical saccade and smooth pursuit as far as the nystagmus was concerned, which was a normal type of eyeball movements, and the cerebellar function test was normal. Calorie test also was normal. Audiometry tests were also normal. The MRI of the brain revealed the presence of an osteoplastic craniotomy scar in the left lateral convexity. Diagnosis of vestibular epilepsy was considered, but the video EEG for 24 hours requested by the patient showed no ictal phenomenon during clinical phenomenon, because during vertigo, even the video EEG did not help. The patient improved by simple psychological counseling and has had no further symptoms without medications, which would say that functional disorders, somatiform disorders are also seen in patients as a cause or a result of vertigo. So the non-neurologic causes of vertigo would be ocular vertigo, severe anemia, cardiac causes and valvular causes like arrhythmias. The carotid sinus could be very sensitive, and that can cause vertigo because of bradycardia. The blood pressure at times can fall in standing position. This is very important for orthopedic surgeons, because when you ambulate your patients, you have elderly people who stand up for the first time after surgery after a day or 2 or 3, and they may have postural hypotension, may have giddiness, and they may fall down. So it would be imperative to check blood pressure both in supine and standing, and then make sure that these patients are good enough to further rehabilitation exercises. And most of the patients also have prostate problems. They're also on alpha blockers, and this further adds to orthostatic hypotension. Nowadays, some drugs are available to treat orthostatic hypotension, and you may tackle over the situation. Hypoglycemia, hyperventilation, psychogenic causes, and certain medications and toxins like alcohol, sedatives, and phenytoin are important drugs which can also result in giddiness, vertigo. Now, a person who was having vertigo for the last 6 months and has had imbalance for the last 6 months. Ramberg's test was positive and everything else was normal, except for the fact that the vibration sensations were impaired. There was a normal MRI scan. What happened was that the patient's TSH was very high, and this was a patient of hypothyroidism who presented with vertigo and giddiness. on replacement therapy, the patient improved and there is no longer any vertigo. So basically, the treatment options for vertigo are antihistaminics for peripheral vertigo. You can give sedatives, you can give them anti-vomiting drugs. The trials are far too many for this, but trials lack that could predict the drug or combination of drugs that will be effective in individual patients. These medicines are not specific to vestibular system, so side effects are also very common. Anticholinergic drugs or antihistaminic drugs are usually effective if the patient is particularly bothered by nausea. Prochlorperazine or metoclopramide is used, and for severe vertigo, sedation is often desirable. In benign positional vertigo, I'm pretty sure that the ENT surgeons would pick up, but these patients usually have vertigo wherein they change position. So even in your examination table, when they turn the head from side to side, or when they stand up or sit up, they would have immense vertigo. And then once their head is steady, then the vertigo disappears. They may not have any hearing deficit. Vertebral basilar insufficiency patients would have hemiparesis, dysarthria, ataxia, diplopia, and this is one diagnosis which should not be missed. Otherwise, your patient is going to go in for a stroke. It's important to know that you are dealing with vertebral insufficiency early enough, because simple measures like antiplatelet agents can prevent a massive stroke in these patients. Hypoglycemia, particularly in diabetics, is a known cause for vertigo and giddiness. So particularly in the orthopedic practice, most of the patients who get operated and who are underlying diabetic patients, they may have hypoglycemia post-operatively or during your hospitalization stay, and they may simply complain of vertigo. A simple blood glucose examination will solve the issue. And hypothyroidism, there are two metabolic factors which can cause vertigo and giddiness. Management, of course, of vertigo depends on whether you are dealing with a peripheral form of vertigo or a central form of vertigo, whether it is an infection like labyrinthitis, or whether it is a toxic labyrinthitis because of high doses of aspirin or ibuprofen, which can also be a cause for vertigo, and you need to stop that. So from my point of view, what we as doctors should know is that in a patient with giddiness or vertigo or presyncope or blackouts, we should always measure the pulse rate for 1 minute and not 15 seconds and multiply it by 4. The reason being that at times you could have sinus pauses, you can have extraventricular premature beats, you can have a very slow pulse rate, and this might by itself be the reason for central vertigo. Always check blood pressure in supine position and standing position, and make the patient stand for at least 3 minutes and then check the blood pressure. In elderly patients, suspect vertebral basilar insufficiency. In young patients, it may be a peripheral cause. And take help if symptoms are not ameliorated by a day or two. And what we should not be doing is that we shouldn't oscillate the heart and come to a diagnosis and say that the heart is normal. We should not read our ECG ourselves and then come to a diagnosis. If the patient is anti-diabetic, we should not ourselves adjust the anti-diabetic medications, and we should give symptomatic treatment for a short while or not for too long without coming to a clear diagnosis. So in short, whenever you deal a patient with vertigo, ensure you understand what the patient really means by dizziness. Try to differentiate central from a peripheral vertigo. Often there is significant overlap between the two. Not every patient will need a head CT scan. Central causes are usually insidious and more severe. They come slowly but very severe, while peripheral causes are sudden but benign, and most of the patients can be discharged with beta-histine and other antihistaminics. Thank you for a patient listening.
Thank you very much, sir. That was very clearly enumerated the central causes and the peripheral causes and guidelines for managing vertigo. If you can stop sharing your screen, sir, please.
Sure. Yes.
So, Sangeet, in our practice, the guidelines are whenever we see a vertigo, the first to see should be a physician. Is what would be the
exactly basic? That is what I was supposed to ask him a question.
Yeah.
Is, like we have patients where we don't find a cause and we shred our responsibility as an orthopedic surgeon and refer to, you see a physician, you see a neurosurgeon, you see a ENT surgeon, the cause is not orthopedics. it is not related to cervical spine, our responsibility is over. A little do we think about the other causes. And as a physician, us orthopedic surgeons, what should we look for? 5 common causes. What we should suspect that it is a physical cause and not related to orthopedics. How do we separate that? Would be my first question.
Yeah. I think patients who come to you would be patients with fractures or whatever. These patients, if they complain of vertigo, obviously you would be looking at a cervical spine. But as any doctor should first suspect whether it is peripheral or central, the thing which you can do at hand would be that most of us have glucometers. Immediately take the blood glucose. This is practically almost non-invasive. Then check the patient's pulse rate. And as I mentioned, for 1 full minute, that gives you a lot of information, whether it is bradycardia, whether it is tachyarrhythmia, whether there are pauses in between, whether the patient has multiple ectopics. And this will tell you that this is a cardiac cause. Okay, without ECG, you know. But then I would mention that we need to have that practice of taking a pulse rate for 1 full minute. Many have stopped this basic test for the patients. I doubt if anybody has taken a pulse value for 1 full minute, particularly beg my pardon that, you know, for surgeons in particular. I don't think that the surgeons have touched a blood pressure instrument for very long. Leave aside the fact that they have checked the blood pressure in standing position. I think these are basic fundamental things. If you are not too keen to do that, tell your assistant or somebody else to do that. But I don't think that these things are simple things which should not be taken seriously, because they are not something like MRI or CT or EEG, which are more complicated than by taking a pulse or a blood pressure. Very simple things. Thirdly, a simple clinical examination, looking at the nystagmus, looking at a Romberg sign, making them walk. When they come in your room walking, I mean, you know, most of the times you know that they are not having dizziness or they're not falling and so on. When they sit on your couch and turn them on one side and they say, oh, they just cling to their head and they don't want the head to be moved even by an inch, you know, you are dealing with this peripheral form of vertigo. So in practice, benign positional vertigo is quite common. Then vertebral basilar insufficiency is quite common. Then autosclerosis, middle ear infections. And if your patient has a short-term fever with vertigo, vestibular neuronitis or vestibulitis is common. But I would rather differentiate between peripheral and central and make sure that I don't miss the central ones. There are many patients who come to me with big tumors of the posterior cranial fossa. Now, the tumor in the posterior cranial fossa doesn't come overnight. It must be landing there for a couple of months or years. And that means many have missed that so far because nobody suspected, because the patient just told them that I'm having giddiness. And everybody thought that this was peripheral. So I think just a subtle, clear-cut clinical examination helps you in most of the patients.
So a clinical examination, and if suspected, going for a MR or a relevant investigation is what.
Absolutely. But don't forget simple things like severe anemia.
Yeah. So basically,
hemoglobin 6 or 7, blood sugar is 50 or 60, TSH normal is up to 5, it is up to 50. Nowadays, B12 deficiencies are very common, particularly those who are vegetarians. That by itself causes anemia and vertigo or giddiness. So don't forget those things. A patient with myocardial infarction may come to you for the first time with only giddiness. I saw one yesterday, and he refused to believe that he has had myocardial infarction. So these things are pretty common. So one has to keep a very wide vision for such common symptoms like fever, headache, vertigo, body aches. One cannot take them casually because most of the times the causes are very simple, but at times you can be caught on the wrong foot, and you would make a big service to the patient by picking up certain difficult cases or sometimes serious patients by just simple clinical examination, so that the disease never progresses further. Yeah.
Thank you very much, sir. I think Dhruv, are you ready for your presentation? We'll invite.
Yes, sir. Am I audible?
Yeah, you are audible. Please share your screen.
Yeah.
So Dhruv would be talking to us about the neurophysician's perspective about vertigo. Welcome, Dhruv. Please go ahead.
Yeah. Thank you. Thank you very much to MOA, Chandak sir, and the organizing team. It is indeed an honor to be speaking in the presence of senior physicians, sir, like Dr. Jay Deshmukh, sir, my colleague, Dr. Harshwardhan Jain, and other senior and eminent faculty from across the country. It was indeed a extremely a beautifully crafted lecture by sir, wherein he included all the aspects that you would from a physician's perspective. And I would now like to narrow it down to a neurologist's perspective. And what I would like to do is I would like to simplify it to how a neurologist would look at it, assuming the all other causes have been ruled out, like hypothyroidism and other treatable causes like anemia and other systemic causes, which are albeit very important, like hypoglycemia and hyperglycemia. So broadly speaking, we have commonly 4 vestibular presentations. You need to remember that. These are caused by 6 different disorders. So these constitute most of the neuro-otology cases that are seen in clinical practice. So 4 groups. Every time you get a vertigo, you should try to put it into 4 groups. And these are usually caused by 6 different types of disorders. And this will rule out most of the vertigo from a neurologist's perspective. Unfortunately, no place for cervical spondylosis in these 6 different disorders. Okay, so the first group is an acute vestibular syndrome. What it simply means is the patient who comes to you with a first ever attack of acute, spontaneous and isolated vertigo. Now, each and every word in this line is important. It is a first attack. This is not your recurrent vertigo or BPPV. It is spontaneous. It is not triggered by any change in position. And it is isolated vertigo, which means the patient does not have anything else other than vertigo. He just has a, now there can be sometimes a fine line between the terms that we use with regards to vertigo and dizziness. As a neurologist, when we use the word vertigo, I would like to use it in a case wherein there is a spinning sensation. The patient says that everything around me, the world around me is spinning as fast like you are in a merry-go-round sort of a thing. And dizziness would be more of a general term wherein it can include imbalance also. It can include giddiness. It can include sort of lightheadedness apart from vertigo. So coming to pure vertigo, wherein you have a sudden first attack of spontaneous vertigo, there are only 2 common causes. Remember this, very simple, but very important. And you don't want to miss an acute vestibular syndrome because it is very disturbing to the patient. The entire family is in panic and you might miss out, as sir has beautifully highlighted, the patient may next day come to you with a stroke. So the first thing is vestibular neuritis or labyrinthitis. And second is the devastating cerebellar infarction. I will come to the details in the later slides. Now we saw what is acute vestibular syndrome. The second group is what is known as the recurrent vertigo. So recurrent means it is happening again and again. This is not the first time that it has happened. And it tends to happen every 1 or 2 years to the patient, maybe every 3 or 4 months. So recurrent vertigo. Now in recurrent, you may have positional or spontaneous. So recurrent positional is the most common that we see, very commonly seen by ENT specialists, very commonly seen by neurologists and by all practicing physicians as well, which is BPPV. That is a benign paroxysmal positional vertigo. I will come to the details later. Then amongst recurrent is again the spontaneous. So what is the difference is that it happens again and again, but it is not position dependent. The patient will not tell you every time I turn to the left or every time I turn in my bed to the right or every time I look upwards towards the top shelf, I get this vertigo. That is positional. Spontaneous means there is no provoking cause. And amongst these, there are only 2 important causes. Sir already told us about Meniere's disease. And I believe Dr. Kapre sir will speak about vestibular migraine. So this is the 2 things that you need to remember. And fourth is imbalance, wherein patient comes to you, wherein he says that he has difficulty in walking or he has some imbalance, which is not exactly a spinning sensation or vertigo, but it's an imbalance. So this can have various different causes. And what you need to do is you need to split your patient into one of these categories. And as with most of neurology, a reliable history is the cornerstone of a correct diagnosis. Remember, no expensive investigations, not always you need an imaging, but a good history is the cornerstone of a diagnosis. So whenever a patient comes to us with vertigo, once you have, how will you put him into these 4 groups? By plain and simple history. So you ask him whether he has this illusion of spinning or rotation, that is vertigo, or is it a drop attack? Drop attack means they suddenly tend to fall down where they are. This is seen with Meniere's disease. Or is it a constant feeling of being off balance? If it is vertigo, then whether it is when you roll over in the bed or when you look up, so this would be help you to categorize the patient into whether it is positional. True spinning vertigo, what we typically get is always temporary. Remember that. If a patient comes and tells you that mujhe 10 saal se continuous spinning sensation ho raha hai, that is describing a physiological impossibility. It is impossible that a patient with true vertigo will continuously have spinning, because after some time, the vestibular system and the labyrinthine system tends to adapt. How long has it been present? Now, it is very important, because if it is lasting for few minutes in a particular position, it would be more likely to be positional vertigo. But if it is spontaneous and it lasts for minutes to hours, then I would be very worried, because this could be an impending vertebrobasilar temporary ischemic event, which may progress to stroke. Is there a significant past history? Now remember, anything new in medicine is potentially serious. Anything old is probably not. So if it is a new thing, if it is the first instance that it has happened to the patient, always be on the red alert and look for anything which might look like a red flag, or then you may even try to investigate the patient on the side of over investigating, but do not miss if it is the first event. Are there any associated symptoms? Now, sir already told us that if my patient along with vertigo has a severe headache or a sudden onset hearing loss or dysarthria, diplopia, I would be very worried, because now this is something which is pointing towards the brainstem ischemic event, which may go into an infarction. So an urgent MRI may be warranted in these cases. Okay, now in brief, in the limited amount of time, I'll just try to cover what is important and how you diagnose. So acute vestibular syndrome, somebody who has come to you for the first time with a sudden spinning sensation, just ask for hearing loss or not. If it is a hearing loss along with this spinning sensation, it may be because of neuritis or labyrinthitis. It is usually one attack. They don't happen again and again. They are spontaneous, so they don't happen again and again. This is an acute vestibular syndrome. And the only other differential diagnosis is the cerebellar infarction. So you need to be very careful. What else could it be? Most commonly, we have herpes zoster, which is the best known viral cause, wherein you can have a viral infection with neuritis and labyrinthitis, and the patient comes to you with an acute spinning vertigo. And the second differential, which you should never miss, is the infarction in the anterior inferior cerebellar artery, which supplies the internal auditory artery. So the patient may come with a sudden loss of hearing along with a spinning sensation, and only an MRI in such a case would help to give the diagnosis. Now, this is something I think I'll spend a couple of minutes on. See, what happens is, if a patient comes to you, whether it is a labyrinthitis or it is a stroke, can be very easily identified by what we call as the HINTS plus test. Now, this test is a clinical test. Anybody can do it. It does not take any great training, and it is 97% sensitive and 95% specific to tell you whether you are dealing with a peripheral problem, such as a vestibular problem, or you are dealing with a central problem, such as a stroke. So what is HINTS? HINTS plus. So head impulse. Head impulse is HI. N is for nystagmus. TS is test of skew. And plus means a new onset hearing loss. So I will show you a video. We'll directly go to the video and I'll explain the HINTS examination to you. Just a second.
Dhruv, I think you'll have to stop share this and again share the video.
Yes, sir. I'll just do that. Yeah, I'll stop share this. Yeah.
The HINTS exam.
All right.
Yeah, share, no problem.
Yeah. So I hope so you can see the video part.
Yeah, we can.
So I'll just come to the relevant parts.
Something on the wall.
So if you see this, sir, I hope I'm audible.
Yes, you are audible. We can see the video also.
Yeah.
Please.
So if you see, this is a normal volunteer and she's asked to look on both sides. So you put a piece of paper on one side, you tell her to look on one side, and then you put a paper on other side and tell her to look on the other side. So you can see that there is no nystagmus. So there is no beating movement of the eye to either side. So this is normal. And now we will go to the patient. So look very carefully at this patient's eyes. So when he is told to look, you can see the eyes are beating towards the left side. If you can see,
Yes.
his eyes are beating towards the left side. And when he's asked to look towards the other side, they don't beat with that much of an amplitude. So this is a unidirectional nystagmus, which would be the fast component is towards the left. So this is reassuring. So I'll pause the video for a while. So what has happened in the nystagmus test is that the nystagmus is on one side. So remember, if the nystagmus is only on one side, this is reassuring to us that this is a peripheral problem. Now, when is it not reassuring? So look at this lady. If you see, look very carefully what happens to the nystagmus when the video starts playing. So you can see the eyes are beating towards the right side when she looks to the right.
Yes.
Okay.
We are able
And
to-
now when she looks to, when we'll ask her to look to the left, the eyes are beating towards the left side. So we got that, right? So a direction changing nystagmus, which means when you look to the right, it beats to the right. And when you look to the left, it beats to the left. This can be seen only in a central cause. It will never be seen in a peripheral cause. And this will give you a suspicion that you are dealing with a cerebellar problem or a ischemic event or a stroke. Now we'll come to quickly to skew. Now what does skew mean is that your eye should be on an equal plane. They should not be up and down. So look at this lady. You can see that both eyes are at the same level. But if you see this patient, you can see that his right eye is little down as compared to the left. So this is what we call as a skew. So skew means that there is a vertical deviation of the eyes. And usually the side where the eye is down is the side where the problem is usually in the brainstem, if it is in the medulla. So you can see that when you do this test, his eye goes up. But as soon as you remove it, it is down. So the important thing to note here is that the skew means one eye is down and one eye is up. And if you see this in your patient, very likely that there is a central cause and it is something to be worried about. And quickly, I'll go to the head impulse test. So if you look, how to do the head impulse test is more important. So you turn the head like this and then you give a jerk. Yeah. So you tell the patient that when I'm moving your head, you please focus on my nose. The point is that when you move the head, the eye should be fixated on your nose or any particular fixed point of the doctor's nose. Now, what happens is in a normal patient, when you give a sudden jerk, the eyes will continue to fix where they are because of the vestibulo-ocular input, which means because of the turning of the head to the left and right, because the pathway is intact from the vestibular system to the eyes will continue to fixate in spite of the movement. But in a patient who has a vestibular problem, the eyes will not fixate when you give the jerk. So this is a normal head impulse test.
Dr. Batra, 1 second.
Yes, sir.
Can you read the YouTube? Next to that is a square icon.
Yeah. Okay.
Can you, can you put a cursor on that? Yes. And now can you replay that?
Yeah. Yeah. Is it okay?
Yes, perfect.
Yeah. So the point is that this is the normal test. I'll just show you one abnormal. Not this one. I'll show you this one. Yeah. Yeah. So just look at this patient.
Yes.
So it may not be very visible initially, but What the point is that once you give a jerk to the head, you see that the eyes go to the other side, but they come back voluntarily. So this is what is known as a positive hints test. I'll just show it once more. Just look what happens when the head is given the jerk, and keep a watch on the eyes. Yeah. Yeah. So just a second. Yeah. So just look at this video once more. So you turn to, when you give a jerk, his eyes come back. So they don't maintain fixation, but the brain later catches it up. So this is what is called as a catch-up saccade, which means that this is a abnormal hints test. So why we have shown this video is that yeah. So why we have shown these videos is that it is just to give you an input that there is something called as a hints test that anybody can perform in any patient who comes with an acute vestibular syndrome. If the head impulse test is positive, if there is no nystagmus on both sides, and there is no skew, which means this is a peripheral problem, you need not be worried much about it. But if the head impulse test is normal, so you need to be worried. If the nystagmus is seen on both sides, you need to be worried. And if the eyes are up and down, which is known as a skew, you need to be worried. So I think this is the message. We'll not go into much detail. Coming to BPPV, remember, if it looks like BPPV, it is more likely to be BPPV because it is positional. If the patient tells you that when they turn on one side or the other, there is increase in vertigo, then there is high chances that it is BPPV. This can be diagnosed with a Dix-Hallpike test. Maybe that is for a later date. And it can be easily treated in the OPD in a single setting by using a Epley's maneuver. So if it sounds like BPPV, it is probably BPPV. And there is no role of hints test here because hints can be used only when there is an acute vestibular syndrome. That is when it is happening for the first time. It is not to be used in a positional vertigo. Meniere's disease, I'll quickly rush through. Important thing which most of us miss is it is unilateral. There is a fluctuating low frequency hearing loss. You may have many patients when you do a pure tone audiometry, they will have presbycusis. They will have hearing loss because of age, but that is more for higher frequencies. So if you should let your ENT surgeon know when you refer a patient that I want to look for low frequency hearing loss, which is very specific for Meniere's disease. Of course, you will have tinnitus, oral fullness, and fluctuating hearing loss unilaterally with Meniere's disease. Some things which you should never miss. These days, we have an autoimmune ear disease. If these patients are diagnosed early or sent to a neurologist early, they do very well with the course of steroids. There are patients who have, when they have recurrent BPPV, let's say they've had 3 or 4 times positional vertigo in the last 2 or 3 years, they tend to develop an anxiety, which results in something known as a persistent postural perceptual dizziness. So they will not fall. They are not worried too much, but they will have a continuous dizziness which will never go. These are the patients who will continuously consult all neurologists, all physicians, or ENT specialists, all orthopedic surgeons, but somehow their dizziness just does not seem to go. And these are the patients which you can catch and treat by treating their anxiety. Always remember, if somebody has a hearing loss, which is bilateral and sudden, this may be a brainstem infarct waiting to happen on a large scale. Always and always try and do an imaging. Never forget patients of migraine. People who have migraine also have balance problems, including vertigo attacks. And many patients with vertigo attacks also have migraine headaches. So that should never be missed. And coming to chronic vestibular insufficiency, patients who have received aminoglycosides or drugs which have resulted in vestibular and cochlear and impairment, they tend to have a chronic imbalance. And you can diagnose them with a lot of simple clinical tests, but this is more for a neurological examination in detail. But at least these patients should not be given a routine labyrinthine suppressant and sent away because it will worsen their problem. So if it is an insufficiency, they may need treatment from other angles. So thank you very, very much. I'm sorry if I exceeded my time.
Thank you, Dhruv. That was wonderful and testing, clinical testings also were good. This Q test and learn a lot of these new things. So that is good, and they are all clinically which can be elucidated. Simple clinical examinations can point to a correct referral. Sangeet, anything from your side?
So I thought the topic was very simple.
Well, so let us learn all these good things which we can see in our clinical practice.
No,
And I
no, no.
hope-
The other side is it is too complicated now. Like
Yeah.
you get a patient who has a vertigo, like after seeing so much of test, we really don't know where the patient should head to.
And that is the idea of this webinar, where we would come down to a conclusion, what would be the right approach and right referral. That is what I
Or it is other way. We would be more inconclusive now.
yeah.
And
So let us, I think
yeah,
Harshwardhan
once we
is
complete, probably then it can be streamlined from the
Yeah.
other faculties.
So we move to the next presentation.
Yes.
Any questions from JD sir to Dhruv?
Well, I think he has made a wonderful presentation, and this symptom of vertigo seems to be very minuscule, but it is such a big issue that the bottom line is just don't miss an impending stroke.
Yes.
Don't miss the posterior cranial foci as well. Peripheral regions, even if they are missed, patients may continue to have symptoms, but they may not have much of neurological damage. But the central one is something which is very bothersome. You should also remember that cervical spondylitis per se never ever causes giddiness or vertigo. Most of the times, everybody thinks that if you have cervical spondylitis, it leads to giddiness. Most of the times, we should never think in those terms. We need to look at the cause, whether that cervical spondylitis is associated with some craniovertebral anomaly or whether there is a vascular problem therein, and try to make sure that ultimately we should do no harm. And the orthopedic surgeon or physician, any doctor for that matter, whichever specialty belongs, he should work like a person or like a German Shepherd dog who would sniff all around and try to find out those patients whom he can just treat them or diagnose it at such an early stage so that they don't deteriorate. So the point is that many patients have multiple symptoms and warning signals or red flag symptoms far before they obviously land up with doctors. And they go to various doctors. Somehow doctors in their daily busy practice are not able to pick up those small red flag like symptoms. If they do, then immediately references could be made and you could prevent a disaster in a patient. For me, there's no point in treating a patient with a vertebral basilar infarct or brainstem infarct. It doesn't help me. But I can be more smart by preventing an infarct by detecting a vertebral basilar insufficiency well enough. Yes. I would be a very bad doctor if I allow my patient with postural hypotension to fall down and have a fracture neck femur and then send it to an orthopedic surgeon. In fact, I should have guided my patient in such a way that he should not have developed postural hypotension. I should have diagnosed it much earlier before he had a fall with that. So I think our job is to pick up symptoms and warning the signs and red flags well before any, you see, patients die suddenly of heart attack, okay? But a disease is prevalent in them for the previous 10, 15 years in terms of some predisposing factors for premature atherosclerosis. Same with strokes. And therefore, we have to be very vigilant in treating our patients, particularly at the internal medicine level. We feel so. Maybe for you, you are super specialist. So patients come to you with very specific things like broken bones and this and that. But here they come to us with very general symptoms. Okay.
Yeah, thank you so much. Dhruv, there is a question for you. Idiopathic prolonged positional vertigo. The question is from Dr. Tushar Agrawal.
Yes, sir. So sorry, what was the question?
About idiopathic prolonged positional vertigo.
I think the terminology now is persistent perceptual. I think he meant PPPD. Yeah. So the point is that what happens is, if you see the patients of a normal vertigo, they are put on labyrinthine suppressants and they do very well after 5 days, even if you don't do anything. But some patients, what happens is now they realize that every time I turn to the left, there is always a chance that I will get a BPPV. And that triggers an anxiety in these patients, as a result of which they feel giddiness every time. So it is a very known fact that any patient who has had a BPPV earlier is a potential candidate to develop this persistent dizziness sort of a thing. And this is a problem which remains untreated. And as Sir has also said, many other things contribute to this, like B12 deficiency, most of the times iron deficiency. They may not have anemia, but they have iron deficiency. So ferritin is low, and they may have thyroid also. And along with the past history of BPPV, all these things come together and they are always giddy. They are so worried, their job is affected, their working is affected. So these patients do very well. You have to give them a low dose of anti-anxiety drugs, and sometimes migraine medicines also for a short period of 2 to 3 months, they do very well. So that is an under-recognized entity, and many of the patients are having loss of job, loss of quality of life, and regular visits to the doctor resulting in financial expenses too much because of this thing. So it should be identified early. So that is PPPD, under-recognized.
Okay, thank you so much.
Yes, sir.
Dr. Chandak sir, are we discussing the medical management now or later?
I think later.
Okay.
Right. So we invite now Dr. Vishal Kundanani, who is eager to present practical tips to manage in day-to-day practice. So this is what everyone would be looking forward to you from, sir.
Thank you, Dr. Chandak, and thank you, Dr. Sangeet, for having me around on this August podium. I hope my slides are seen, and I'll just move ahead if you give me a go ahead.
Please.
Yeah, please go ahead, sir.
Thank you, sir. So this chakkar pe charcha and the whole chakkar that we are going through is almost like a chakravyuh, and more so when you are a surgeon, an orthopedic surgeon like me, who are often wrong but never in doubt. Jo maine kiya wahi sahi hai. And so today I'm going to be probably telling you about jo maine kiya kya sahi kiya. The galat and sahi of it can be then discussed over the charcha that may come across later. I'll just present some cases that are real-time stories from my own practice, where a young lady like this walks into a clinic, an executive with neck pain. It's so common. I mean, being a spine surgeon, you only get to see patients who are having musculoskeletal pains, and symptoms like these are extremely, extremely common. Believe me, I see almost 5 patients with exactly same clinical profile where neck pain is the primary complaint. And sometimes, off and on, they will have this gradual onset, recent worsening of symptoms, which may be having dizziness, oblique giddiness, oblique vertigo, the definitions of which I really don't understand. But the patient से चक्कर आता है. कभी-कभी चक्कर कम आता है, कभी-कभी ज़्यादा आता है. Sometimes it just worsens. And the movements of my neck are painful. Sometimes they are associated with this chakkar thing. And any movement sometimes can actually be precipitating my spinning of the head or spinning of the world around me. On your examination, obviously you don't find very obvious findings, and that's when you term it to be spondylosis, which was also written on the X-ray that this patient is carrying with you. And this patient then is already carried away with the diagnosis that is on the mentioned paper of investigation. And we also, it's a very common story. We also tend to get carried away with this. So the question that arises, after having a preliminary self-assumptive diagnosis of cervical spondylosis as the cause of such clinical profile with neck pain and some spinning around, some dizziness, what is the next step that we should do? In practical life, what is the next step that we should be doing with this? Dr. Sangeet, Dr. Chandak, what is your approach to this? A quick comment on this, sir.
So basically, most of them initially in first or second consultation are managed conservatively with either some recommendation for physio, analgesics, and supportive drugs. It is only when they come in the second or third that we proceed for an investigation. That is what the routine story is with most of the common patients of neck pain and associated symptomatology.
Right. So, Dr. Sangeet, is this a common story in your practice also?
Yes, exactly. Mostly a conservative treatment, and they settle down over the time.
Right. And if they don't settle, then you start getting worried, right?
Yes.
But we generally tend to shove away all these vertigo patients, dizziness patients under the blanket of the same treatment care that I have mentioned here, right?
Yes. Most of the time, initially they are labeled like this unless they come
Yeah.
again with the symptoms, and then we start thinking about the previous diseases. And by the next visit, usually we tend to recommend them a MR. So this
560,000 general physicians across country belonging to different associations believe in the same philosophy. I actually did a survey of 53 general physicians in last 7 days, and 98% of people believe that their first symptomatology with this kind of symptoms, they will deal with exactly what we have just discussed here.
Yes.
Sometimes they would actually go ahead and do a MRI. Is that a common situation, sir? Dr. Sangeet?
Yes.
Dr.
Yes.
Chandak?
Very common.
And MRIs generally tend to have some very wonderfully written 3-page report, which none of us actually understand ki iska clinical significance kya hai. 3-page report, sometimes signed by 3 or 4 radiologists together, saying that there is a DDD at 4-5, DDD at 5-6, DDD at 6-7, mild traversing nerve root, mild exiting nerve root compression, mild degenerative changes, mild osteophytic changes are there.
And now,
at the end of it,
now if you utter patient that this is normal, they rarely accept it.
Yeah.
No,
But
they come
we
with the
generally-
diagnosis.
Yes. So what was the diagnosis?
I have a disc prolapse at 2 levels, and I have a chakkar. What do I suggest? What do you suggest?
So I am going to tell sir what I exactly practice, but I am here to ask what is the general consensus? What do we do with this? I mean, we are all orthopedicians, as I said, often wrong, but never in doubt.
So do we take the opinion from physician? What they would recommend?
Yes. Let's have this.
Sir, what would you recommend here in this patient?
I would have a detailed neurological examination first, detailed history, go for basics like CVC, random sugar, TSH, look for anemia and so on. And there is some degree of hyperreflexia mentioned, numbness in hands, right more than the left. I think MRI would be required definitely. And that's it. Yeah.
So Jay sir, after listening to your talk, I actually prepared myself and went into the history of this patient. And believe me, this is a young executive from a bank, extremely apprehensive. So hyperreflexia, I think it is something that maybe subjectively a perception of us being hyperreflexive, but there is no other medical problem at all. Thyroid, blood pressure, drug history, and sometimes we as orthopedicians also take history. Sometimes, when there is a beautiful female, we would rather spend more time asking out everything around there. So everything is normal here.
Yeah. So the disc on an MRI, does it correlate with the right-sided symptoms, neurology symptoms?
No, actually, she doesn't have any pain in the upper limbs. There is no radiculopathy kind of situation.
The numbness in the right hand is more than the left.
But the axial scans don't.
The MRI, which can be picked up to correlate that.
So it doesn't really correlate, sir. Doesn't correlate. I mean, take my word on that.
Okay.
Yeah.
Okay. Very often we find these findings, and we label it as cervical radiculopathy and keep on continuing with analgesics and all those gabapentins, etc. This is what the routine story is. The next third day they come down, sab goli khaya aur bahut chakkar aa gaya, sona hi pada. Is what the story would be then now.
Yeah, and she is already on treatment. You can see that the diagnosis spondylosis in her head and hand and X-ray, and now MRI is done. Very apprehensive actually. MRI being available so offhand, she has actually gone ahead and did an MRI also. Now it's on your face. What next, doctor? What is to be done? Jay sir, अभी क्या करने का आगे?
आगे give symptomatic treatment and observe her. Follow her back after 1 month.
And observe means call back in 1 month and expect what, sir?
Expect whether there is some neurological deterioration, whether there is any symptomatic relief. Okay, there's straightening of the spine little bit, and reassure her that there's nothing majorly wrong with her spinal cord as such for the time being. Yeah.
Right. So fortunately, the flourishing $100 billion industry flourished even more when Dr. Chandak, Dr. Sangeet, myself, and Dr. Jay recommended the same treatment that most of the general physicians across the country would do. They send the patient to physiotherapy, started on medication, vitamins, injections. Some people also recommended traction. She started wearing collar. So from a white collar person, she became a with collar person. Unfortunately, in 3 months, started developing gradually onset progressive myelopathy. What went wrong, sir, here? Jay, sir, now we are a party to a patient who's an executive, well-read, has come to us with this X-ray, this MRI, and we have pushed her into development of myelopathy. What went wrong? Anything that we could have done differently, sir?
We could have got a CSF examination done. We could have had a MRI with contrast.
Yeah.
Are we dealing with OPL?
So in this patient, the only thing that came across positive was a flexion extension X-ray showing C1, C2 dislocation. And this is not uncommon. Take my word. I see so many C1, C2 instabilities. At least 50% of them have associated vertigo, dizziness, giddiness symptoms associated with myelopathy symptoms. And sometimes that can be the only presenting symptoms in patients with C1, C2. What I'm trying to draw the attention to is that not all patients with vertebral artery compression will have C1, C2, or patients with vertigo will have this pathology. But this, though being rare, is one of the causes of vertigo, and this can only be caught when our heart is thinking about it, when our mind is thinking about it. So eyes will start looking for it when our brain actually has registered this kind of pathology. And MRIs like these are very common. Case scenarios like these are very common. Another case scenario where a golfer, 63-year-old male, like one of our mentor, Dr. Tanna sir, who is an avid golfer there, and having neck pain and dizziness is like the second commonest symptom after back pain in our clinic, where neck pain with some dizziness, with some shoulder pain, difficulty in turning due to head spinning is such a common scenario. And invariably, we generally tend to shove away these symptoms under the carpet, saying that medical management, physiotherapy, traction, and because your drug history is normal, because your hypertension is okay, because you don't have thyroid history, because your medicines are okay, because your BP is good control, you don't have anemia. So please go and manage conservatively. Unfortunately, all this flourishing billion-dollar industry is only happening because we do not tend to be very, very stringent and meticulous in diagnosing it. We must understand that vertigo is a multidisciplinary problem, and a single person, single specialty approach may sometimes not work. And like we started, that sometimes we may have to call upon our physician friends, neurology friends, ENT friends, auditive friends to understand whether there is something that we can together help this patient. Like in this patient, a MRI with such a simple tiny history of weakness in the left arm showed some parietal fossa tumor. So these are things that are not uncommon. Vertebral artery insufficiency, MRI angiography of neck vessels just proved that there is a vessel constriction there resulting into the vertigo or dizziness that the patient had, and OPLLs can contribute to it, auditory meatus dilation. So all these things, though are rare, but are very commonly seen in specific specialties. This is something that I would never even be able to dream about it unless now I opened my eyes. This is something that I would never dream if the vertigo is persistent. I have not been following up this patient. And tumors like these, I rarely do a screening of brain unless until I'm really very, very stringent and have a very high index of suspicion of things going central or peripheral about vertigo. The question now arises is, should every patient of vertigo be subjected to MRI and high-end investigations? I think the previous speaker such wonderfully highlighted the importance of such clinical examination points. And all these clinical examination points can actually help us to understand which patient should be subjected to higher investigation. And for this, what we need is a simple clinician's approach, a clinical approach, though we are orthopedicians, often wrong, never in doubt, but a simple humane touch to our profession, having an extremely high index of suspicion and believing that vertigo sometimes can be nasty. It can be having a hidden cause inside, and it is a problem of multidisciplinary approach where even a neurologist may not be able to find all the causes of it. Even a physician or a ENT guy may not be able to find all the causes of vertigo. Sometimes a hidden C1, C2 subluxation, which just requires a flexion extension X-ray or a check of the rotation of the neck, will be able to help the diagnosis of vertigo. And for this, what we need is an extremely high index of suspicion and a belief that someone or the other among the team may be able to come to a conclusion of diagnosis and keep a stringent follow-up on these patients if they are not getting better. And this chakra view, we all can only break when we have this multidisciplinary approach to it. And for this, I am sure previous speakers have all spoken about it. But for this, we need to understand that vertigo cannot be caused by a single system pathology, because the balance is purely decided by afferent inputs from multiple organ systems, which includes vision, afferent impulses from vestibular system, neck muscles and joints, and of course, the foot and somatosensory efferents from the joints also decide how the efferents will reach to these joints or give a sensation or the stimulus or the presence of a person's head in orientation to the space. This is what all balance is about. And so any problem in vision can result into vertigo, dizziness, or disorientation. Any problems in vestibular system, any problems in neck system, and any problem in joint system. A simple peripheral neuropathy can be perceived as dizziness or disorientation of a person in space. So this is something that we must understand, that the physiology of balance decides and tells us about the etiology of vertigo. It can be a problem of receptors, it can be a problem of transmitters of the afferent impulses, or it can be a problem of perceptors, which can be in brain directly due to a lesion out there, or due to a reduced blood supply in the cerebellum or cerebrum. So these problems can arise anywhere and can be a cause of vertigo. Just shoving it under, telling that this vertigo is simple and easy to treat with medical treatment or physical treatment may be a overkill, or sometimes missing upon some very, very important pathologies underlying, which can be treated easily at the early stage. What is the clinician's role? I think Dr. Jay Deshmukh very, very wonderfully highlighted about what and where, how should we start with. This is what I follow. Even before the patient sees me, there is a printed chart, which I would love to share, maybe if given a chance, where a drug history is taken in absolute detail for every patient, irrespective whether they have vertigo or not. These small problems, whether the patient has hypertension, diabetes, is on some kind of medicines, because change in hypertension medicine, change in diabetic medicine, change in presence of opioids or substance abuse, thyroid, can easily lead to a simple situation of vertigo, which by just managing drugs in a clinical setting, you can easily manage vertigo. Steroids, myelopathy presence, previous history, lifestyle histories can also help you to understand whether this patient has any kind of exercise or has been having a constant posture on executive lifestyle to result into disc osteophytic complex resulting into cord compression. Presence of central nervous issues, a tongue putting outward. Simple test tells you whether there is cranial nerve dysfunction or not. The eye movements, our previous speaker just highlighted about it. And of course, a small detailed examination about hyperreflexia, presence of peripheral neuropathy, eye, ear, a history of tinnitus, hearing loss, or putting a mastoid process examination will just tell you whether there is any tenderness out there or not. So these small things in a clinical setting may take 5 minutes, but it will actually tell you whether you need to subject this patient to higher investigation or not. And if most of this is normal, doesn't mention anything significant, you can rest be assured that counseling and reassurance with medical management generally does helps, which may actually be the case in 90% of patients, and 10% are the only ones which you'll be able to pick up. So red flags can be picked up in your clinical setting if you just devote that extra 3 to 5 minutes to get this history done in your clinic. When it comes to cervicogenic vertigo, I think it's purely a diagnosis of exclusion, and the triad of neck pain with dizziness, which means a sense of imbalance, along with symptoms which increase with neck movement. Unless these three triads are present, I do not label any vertigo as cervicogenic vertigo, and there is always something or the other that needs to be looked at. Of course, cervicogenic vertigo can be a contributory factor to a central or vestibular vertigo, but it can still be contributing to it. However, if this triad is present, my focus goes towards cervical spine more than anything else. And unless there is a triad of these three things, a conclusion that there is cervicogenic component to vertigo doesn't travel into my brain. And I would rather focus on peripheral or central issues or drug history or lifestyle modification, which comes into picture. And then the mechanism of cervicogenic vertigo is very well described. It is very simple because of osteophytes coming near the foramen traversorium, where your vertebral artery gets compromised in particular movements. That's when your vertigo starts. Sometimes because of your muscle weakness, afferent impulses that are required for better proprioception or presence of head and neck in space orientation gets compromised due to muscle weakness. And this can easily be also termed as chronic arthritis, or commonly called as Barreau syndrome. Sometimes after surgery, CSF leak can also be perceived as it. And there are patients who come after post-operative regime having this vertigo kind of feeling. Again, you should be highly suspicious whether the wound is dry, if there is a bulge out there, if there is a presence of cough impulse or anything of that sort. And of course, neck does interact with other systems to get a sense of orientation. That's why this all physiology, etiology, and the pathophysiology of vertigo must be understood to really understand how a neck can contribute to the vertigo feelings and symptoms. And this often gets very, very easily mixed with benign paroxysmal vertigo and also what we call cervical artery dysfunction, which can be actually a primary cause where only MRI neck angio can tell you. So if all the other things are okay and you really feel that patient still has some cervicogenic component of vertigo, please do not hesitate to go ahead and do a MR angiography of neck vessels, and you'll be surprised to find some findings, at least in 10% of your patients, which may or may not need intervention, but at least a documentation is something that may really be warranted in all such case scenarios. Now, how do we rule out? We have seen all the tests. How do we rule out the positional test? By doing provocative tests, and nystagmus by again examination of the eye. All these tests we have just seen there. But a very simple thing is try and do these provocative tests. You'll be able to find out whether it is benign positional paroxysmal one or there is a central and vestibular cause to the vertigo. These are very, very simple tests available on YouTube and Google. Just read through them, and it takes hardly a minute's time to do these tests to rule out if the vertigo or dizziness is purely from vestibular or central component, and you'll be able to find out and at least diagnose that these patients require a higher investigation. How do I treat them? Once I ruled out and excluded all the other major causes, then I think my approach is very simple. My job becomes so simple that we are aware about the basics of treating vertigo. It primarily involves lifestyle modifications about posture, getting their muscles better, proprioceptions better by promoting exercises, promoting walking, endurance build up, and of course the neck movements and the lifestyle modifications are promoted along with medication. And sometimes, rarely though, but surgery does helps in such patients where there is the identifiable cause of vertigo. We all know these lifestyle modifications. Basically, most of these are executives having constant posture, and so have muscle fatigue very often, and that's what is something that we need to really work upon. Getting up from bed, there is a specific posture called Brand-Daroff exercise that has to be explained to them. And this is like, it's like allergy. When you're allergic to something, you tend to desensitize yourself by exposing yourself to a lower dose of that particular sensitizing agent. And that's exactly what you do for most of these cervicogenic or benign paroxysmal vertigos also. You expose them to smaller stimulus very often in the day. That's how they get desensitized to this particular thing. Exercise for neck are important. We all know these simple neck exercises to stretch and strengthen your neck muscles, but eye exercises tend to play an important role, and not in isolation, but in coordination. This is what we call oculomotor exercises, where you fix your gaze and move your neck versus you fix your neck and move your gaze. So these exercises again are available on YouTube. What in my general practice I do is I have downloaded some links from YouTube and I send to all my patients who require these exercises, and they can just go through the YouTube and learn how these exercises can be done. The problem is that most physiotherapists or most of our colleagues, except few, do not spend time to counsel, reassure, and explain these type of exercises, because they really tend to have a wonderful effect on the symptomatology of the patient if they are really sincere and disciplined to do the exercises. Medications, we just heard some previous speakers speaking about them wonderfully, but in my practice, what I do is I actually believe that these medicines have their own pros and cons, and I start at high doses and taper them like how steroids are used. I generally believe in Vertin starting with 16 milligrams thrice a day for 7 days, followed by twice a day 7 days, followed by once for next 7 days, and that's how you taper and give them a maintenance dose. If they have problems which are associated like nausea or very, very severe vertigo, like Dr. Jay, I believe in his philosophy also that we sometimes offer them steroids or sometimes even sedatives for that matter. Pain management comes into picture if there is associated pain, and of course vitamin supplements is very important. If the vertigo is very grossly related to C1, C2 rotation, cervical collar does tend to help, and that's the only time when I use cervical collar. Surgery does come into picture when you have identifiable C1, C2 instability, or an Arnold-Chiari malformation, or a Klippel-Feil syndrome, which I think most of us sometimes miss upon because our vision stops at C2. However, there are craniovertebral pathologies which can be contributing to this, which are actually treatable surgically very, very well. We have been doing these cases very often, and in the last 15 years, we have done more than 500 such cases which have either primary or associated vertigo complaints due to one of these pathologies. Some of these examples were a non-union odontoid in a young male. He had a trauma in childhood, whether it's a os odontoideum or it's a non-union, but this patient rarely presented only with vertigo and some early hyperreflexia signs walking into clinic, and we did a transarticular screw and he was actually better. Degenerative C1, C2 arthritis, again pinching on, you can see the osteophyte really pinching on the vertebral artery. Again, this requires excision of the osteophyte and fixation of C1, C2 joint, really works wonders in such elderly patients. And Klippel-Feil anomalies and Arnold-Chiari malformations, like here you see, we have been treating them quite often, where surgery does really helps not only take care of the neurological symptoms, but also the vertigo, which tends to get better in these patients. So to summarize, vertigo, it's not a single clinician's job, but it's a clinician's job, which requires a multidisciplinary approach. But the most important thing that you need to have is an extremely high index of suspicion and a human touch to the patient that this can be treated and we can come out of this Chakravyuh very well. Sometimes we may need help of other super specialties, which I generally tend to take an opinion of my ENT and neuro colleagues to help us reach out or at least exclude major pathologies if at all there are any associated one. And cervicogenic vertigo, I think it's a pure diagnosis of exclusion. I would rather treat them simply if I have got all the other pathology excluded with the help of my clinician friend there. Thank you so much, sir.
Chandak sir, unmute yourself.
Yeah, thank you, Sangeet. So that was a wonderful lecture pointing towards the importance of C1, C2 and craniovertebral junction anomalies as well. Thank you so much, Vishal. Any questions to Dr. Vishal? Sangeet?
Vishal, does that mean any patient who's coming with cervical spondylosis and a vertigo, you would advise MRI of the cervical spine, MRI of the brain, and MR angio?
No, sir. Again, as I said, every patient with cervical spondylosis may not have cervical spondylosis as the cause of vertigo. The first things that I do is generally tend to take a simple history in detail. If there is any, because most of these patients who have associated severe cervical spondylosis will also have some or the other medical problem prevailing, be it hypertension, be it any diabetes, thyroid, they are on some kind of medication, they may be suffering from hypoglycemia, they can be having postural hypertension, whether they have had similar episodes in past, are they on any some kind of medicines, do they feel this vertigo only after a good night of Friday night drinking session with their friends, or they have it only after a certain kind of posture. These small pointers will help me understand whether lifestyle or pathology is the cause to it. After having treated them, I generally also tend to reassure that though at this time I am not able to find the exact cause of it, but sometimes to come to a conclusion for the exact cause, we may have to not only take multiple opinions from different pathology people, but also may have to do investigations, where my investigation, if my colleagues have already ruled out neurological and the vestibular cause to it, would be a MRI cervical spine screening from C1 to C7 with screening of neck vessels and brain. So dedicated study comes into picture only if they find a pathology of that area. It is primarily a screening study. You just may have to call your radiology friend to tell him that primarily this MRI is about screening of these three areas and dedicated study of one area where you find the pathology.
So most often you'll get a MR angiography as well. When this
Always
patient...
associated if vertigo is a primary complaint of the patient and there is no obvious neurology. So I'm not looking at cord compression as my primary pathology, but I'm actually looking at MRI brain screening, screening of neck vessels and screening of cervical spine, plus dedicated study of affected area.
And there is a group of patients whom, like they have seen most of the consultants, they still have persistent vertigo. As you say, like you taper the medicines over 3 weeks. What do you do at the end of, say, 1 month? They keep on coming. They have mild degenerative disc disease. And since it is reported or since it is in the X-ray findings or the MRI findings, the ear specialist or the neurologist or the physician, they tend to send you back to you. So how long you can continue the treatment, medical treatment, and what is the solution for that?
So if you really contemplate to this situation, sir, you would agree, and I'm sure most of the August panel here would agree that such type of patients who have persistent vertigo without the identifiable cause is less than 0.5% of the total number of patients of vertigo. And in such patients, using a chronic medication is not a bad idea, provided they can tolerate it without the side effects. Anticholinergics, antihistaminics have their own problems, be it beta-histine, be it cinerazine, be it domperidone, or for that matter, any sedative, or for that matter, any other drug. If they can tolerate it well, my usual idea is to taper it down in 3 weeks and continue a maintenance dose and try to cut the dose down in 2 to 3 months time if they are chronic symptomatic patients without any identifiable cause. But I'm still of the view, I really cannot remember any such patient, at least not very recently, who has had chronic symptoms persisting for months and he has still stuck to me. Fortunately, such patients where the cause is not identified, your medicines are over, they would either leave you or they'll get better. And so we are so fortunate that any such patient will not continue to visit your clinic for a very, very long period of time, unless they really find an identifiable cause for which you have put them on chronic follow-up.
So you said, Vishal, start cinerazine, etc. in the full dose and then taper down. Any pharmacological relevance of that? What is the
So my first drug of choice is beta-histine, Vertin. Okay. That's because that is one that in my practice I feel has the least side effects. Most patients will not have anything. The commonest side effect of beta-histine is either nausea, headache, or bloating of abdomen. and these are like using a painkiller, you know. So they, if they complain, we taper the dose. But if you're using it for 3 weeks, generally this is something that's very, very tolerable. Cenerzine or Stugeron, on the other hand, is not only has sedative effects, not only gives higher bloating, but also has a tendency to put on weight. And I generally tend to not mix the two drugs together, because that is when patients sometimes have associated headache also when I mix these drugs. So for my primary treatment is always with Vertin, sometimes addition of domperidone, and rarely addition of the third drug. But I think the physician friends will be able to help us how and what medicines they start and how do they taper and continue. Dr. Jay, Dr. Dhruv?
Yeah, well, I think, basically, once you are sure that you have not missed anything major, like, cranial-vertebral anomaly or any vascular problem, you start them on symptomatic treatment, as you have already mentioned. Most important thing is reassuring them all the time that there is no brain tumor, you're not heading for paralysis, your hearing is normal, so don't worry. So that is important. Third is adaptation exercises that you would do. And as you rightly mentioned, that none of these patients really require medicines for more than a month or so. If they do require, then again, you need to just go back and see whether you're missing something there. It could be simple hemoglobin being low, diabetes not being checked up properly, hypothyroidism, which could be subclinical at times, and you move forward. But then you need to ask yourself if the patient is not improving symptomatically, even after 1 month of therapy. Most of the times, as you have rightly mentioned, and Dr. Dhruv also has mentioned, that once they have that BPVV, they just get conditioned to that sort of symptoms so very often that even after 30 years, they would hold on to their ears and then gradually go and be flat on the couch. And when you ask them to turn over, no, if I turn on that side, I'm going to get a severe vertigo. So I think basic thing is that when things go wrong, reassure them and try to rethink over the whole issue again.
I think the only thing that really is a big warning sign, which Neeraj has also mentioned in his chat box, that living with giddiness for a month's time, it's a major challenge, particularly for a working male or female who has to drive down from one place to another. It can be a major challenge. The quantum to this is, how do I quantify how aggressive I have to be in investigation? Purely depends on how the functionality is affected. Well, if the functionality of the patient is affected, aggressive investigations day one.
Okay.
I do agree with you, but I think one must remember that vertigo is after all a symptom. If both of us have a similar clinical problem, you may have more symptoms, I may have less symptoms. Exactly. And the functionality also depends on the symptoms. So I think reassuring a person is the first thing that you need to do. And second thing, which I have learned in practice after a long time, and I do understand it from the very beginning, is that a detailed clinical examination of the patient is very reassuring to the patient.
Yes.
You examine them in detail, check the blood pressure, supine, standing, make them walk in front of you, make them suddenly turn and get back to you when they're walking your clinic. I think this reassures them, and this really rules out most of the clinical problem without going for major investigations. And once they know that, well, nothing is going wrong with me over here, why am I complaining about vertigo all the time? They get reassured, and you need to reassure them all the time.
True that.
Thank you. Thank you very much. And after getting a lot of referrals for MRI and MR angiography, Harshwardhan is ready to present his workload of MRIs for vertigo investigation. So Harsh, can you please share your screen and go ahead?
Sure, sir.
Yeah, we can see your screen.
Yeah. A very good afternoon, everyone. After those fantastic clinical lectures, let us move on to imaging. We'll be discussing about the role of MRI in vertigo. So the outline of my talk is relevant MRI anatomy, clinical cases, and then summary. So what are the imaging modalities we use for vertigo? Now, we all know that MRI is the imaging modality of choice with MRI angiography. MRI includes scanning of internal auditory meatus, cervical spine screening, CVJ imaging. But there are few cases in which HRCT temporal bone is the imaging modality of choice. Like sometimes a cholesteatoma or a otitis can be a cause for vertigo, in which or a fracture in which the HRCT temporal bone becomes the investigation of choice. Carotid Doppler, it's just a screening modality to look at our vertebral arteries. But sometimes in cases like subclavian steel phenomena, carotid Doppler becomes the diagnostic modality. So we'll move on to the normal anatomy. What are the structures we look for when we are looking at the patient of vertigo? So other than the routine MRI sequences, what we generally do is a drive imaging. Now this video is of a drive image, which is a highly T2-weighted image. We specifically do look at the central vestibular pathway. Now these are the lower axial sections of our brain. This is the cerebellar hemisphere. These white structures are the folia. This is the CSF. This structure here is the medulla oblongata. We can see these two dark dots here. These are our vertebral arteries. These are the lower cranial nerves. Now, once we are moving higher up, we are coming to the most important structure, the 7th and the 8th nerves, the facial nerve and the vestibular cochlear nerve. So, and this is the internal auditory canal. Now, we are seeing this a cauliflower-like structure here. This is the cochlea. Again, this is the pontomedullary region. This is the vestibule here. Yeah, these are our semicircular canals. This is pons, the 4th ventricle, cerebellar hemisphere. And then higher up, we have the basilar artery, the midbrain. So this is an important anatomy of central vestibular pathway. These are the 3D MIP images, which shows the structures. Here, the 7th, 8th nerve complex, the cochlea, and the semicircular canal. Any disruption along this pathway can lead to vertigo. Now coming to the MR angio images, again, so what sequence we take a time of flight sequence, which is a non-contrast scan. So we don't give any contrast for MR angio. This is the angio of neck. We can see there are 4 bright dots. So these are our common carotid arteries, the right and the left common carotid arteries, but we will be focusing on vertebral arteries, the right and left vertebral artery. This is in the region of neck. So as we all know, the vertebral artery will be going to foramen transverse areum in the cervical vertebra. In the neck region, here the carotids have divided into the internal and external carotid artery. We can still see the neck portion of the vertebral arteries. Moving higher up, the vertebral arteries are entering into the brain. So again, I would like to focus on, this branch. So this is the pica, posterior inferior cerebellar artery, which comes from the vertebral artery. Any occlusion in this vessel, patient can present with vertigo due to medullary infarction, acute medullary infarction. Yeah, this is the intracranial anatomy of the vertebral arteries, where the 2 vertebral arteries will join to form a basilar artery, which will give anterior inferior cerebellar artery. Again, a very important branch. Any occlusion can lead to vertigo. Higher up, it will give the superior cerebellar artery. And finally, the basilar artery will divide into posterior cerebellar arteries. So this is about the vertebro-basilar anatomy. Usually on films, these are the images which we give. So this is the vertebral artery, which is arising from the first part of subclavian, the neck portion of vertebral artery. This is the intracranial portion, where we can see that the 2 vertebral arteries are joining to form the basilar artery, which is again finally dividing into posterior cerebellar artery. So these images, we need to see any loss of flow void, any flap, any thrombus within can present as vertigo. So after keeping this anatomy in mind, we'll move on to few clinical cases, and we'll be focusing on MRI images. So this is a 64-year-old, known hypertensive, vitals, normal, acute onset vertigo. Now, after listening to all the previous talks, we all know what we are looking for. So these are the diffusion weighted images. There is a bright signal here in the medulla oblongata. As we saw on the normal images, this is the area of medulla oblongata. So this represents an acute infarction in medulla oblongata. What we are seeing on MR angio images, see, these are the carotids. These are the vertebral arteries. So you can see the normal right vertebral artery, but what is happening to the flow void here? It is absent. So there is a thrombosis of the vertebral artery, which has resulted in acute infarction. Again, it's important that we should be aware both the vertebral arteries are not of same size usually. So we have usually one of the vertebral arteries will be hypoplastic. This doesn't mean that that is pathological. The absence of flow void means that it's an abnormal image. So this was a case of acute left medullary infarction, again a vascular cause for vertigo. Case 2, 31-year-old woman who presents with right-sided vestibular paresis. Now, this is a T2 weighted image. We are seeing a bright signal lesion here in the cerebellar peduncle and the brainstem region. When we screen the upper cerebral hemispheres, we saw that the similar plaques were also seen in the periventricular white matter. But the patient was symptomatic for this plaque and had presented with vertigo. So this is a case of multiple sclerosis. Any inflammatory lesion can present as vertigo. We have a companion case here where a 40-year-old female presented with acute onset vertigo, dysarthria, and ataxia. So this was an acute presentation. There was no history of fever. We can see these plaques here in the brainstem, a larger one, and some kind of a post-contrast enhancement. So actually this patient came out as an emoji antibody positive encephalitis. So even such kind of encephalitis can present with acute onset vertigo. The important part is the location in which the lesions we are seeing, which causes the symptoms. The pathology can be anything from infarction to the tumor. Case 3, 24-year-old long-standing vertigo, bilateral hearing loss. So again, these images, they speak for itself. We can see that there are large enhancing tumors seen in bilateral internal auditory canal. This is a classic case of bilateral acoustic neuroma. So this patient was neurofibromatosis type 2 positive, in which bilateral acoustic neuromas are known. But sometimes the tumors may not be that big. So in such cases, having a close look at our drive images, like in this case, we can see a bright signal in the labyrinthine area, which is showing post-contrast enhancement. This is a case of a very small intralabyrinthine schwannoma, which was a cause for vertigo in this patient. So tumors may be very small. In such cases, a high degree of suspicion when rest of the brain and examination is normal, it's always good to give contrast. Case 4, 18-year-old sports injury, vertigo. Now, this patient had fracture tibia also, for which he had gone to meet an orthopedician and had the vertigo also. So the patient was sent for MR brain with angiography images. Now, what we are seeing on angiography images, now we know the anatomy now. This is the right vertebral artery. This is the left vertebral artery. There is some kind of an irregularity along the right vertebral artery. And these are our source angio images, which shows kind of a flap within the right vertebral artery. So while trauma, there was a vertebral artery dissection, which was the cause for vertigo. This is how a vertebral artery dissection will look on MRI. Yeah. 38-year-old male, acute onset dizziness and neck pain. Now, this patient, MRI brain was normal, MRI spine was ordered, CVJ looked okay, cord is okay, not much of disc. We are seeing some kind of a bright signal here. On axial images, we can see there is an inflammation along the longus colli muscle, and CT images showed calcification. So sometimes these rare causes can be a cause for vertigo, neck pain. This was a case of a longus colli tendinitis. Coming to the last case, 25-year-old with a long history of episodic vertigo. Now, again, these the cord is normal, not much of disc, but what we are seeing, there is an accessory ossicle on the close to the base of the clivus. So this was a case of a condylus tertius, which due to which the patient presented with cervicogenic proprioceptive vertigo. So we know that GRE malformation, the tonsillar herniation, CVJ anomalies can be a cause for cervicogenic vertigo. So just to summarize my talk, what modality we should use in vertigo. Now, in a suspected case of BBPV, Meniere's disease, migrainous vertigo, or a viral neuronitis, where we are seeing that there are no atypical features, we don't need any imaging. But if there are atypical features like unilateral or asymmetrical or audiological symptoms, MRI brain with internal auditory meatus dedicated study should be done. In the cases of central symptoms, there is no doubt MRI imaging is the MRI brain is the imaging of choice with angio SOS. Now, in cases of chronic otitis media or acute otitis media, in suspected cases of semicircular canal dehiscence, again, HRCT temporal bone can be a good imaging to use. So this was about the imaging. I would like to thank Chandak sir and MOA to give me this opportunity to present this talk. Thank you.
Thank you, Harshwardhan. That was wonderful summarization of what investigation to use and showing us all the cases of problems with the circulatory system. Thank you so much.
Thank you, sir.
Any questions to her from faculty members? Or we move to the next talk by ENT causes are also really very important causes of the vertigo, Meniere's disease, etc. So,
Can you stop sharing screen, Dr. Jain?
Well, I think coming to this Dr. Harsh's talk, it was wonderful. It's very important to have a good communication with the MRI specialist or radiologist and a referring doctor, because many a times I've seen that there is a lot of miscommunication or no communication at all, and it is very difficult for the MRI radiologist to concentrate on what part of the vestibular system or the brainstem he needs to concentrate upon. And therefore, sharing the patient's history, clinical findings to the MRI radiologist is extremely important, because that makes his work easy. Like, he just suggested that vertebral artery dissection. Now, unless until a person would know the history, he would not go step by step and see every part of the vertebral artery when he's doing the MRI angio. So I think a sharing of details about the clinical history and the patient profile with the concerned radiologist is of most importance. And then looking back as to what one could really do to that patient and sharing the clinical outcomes of a patient also would help the radiologist the next time that he would see a similar patient.
Absolutely, sir. I agree with you, because most of the times when I get requisition, the only thing written is please provide concession. I don't have any history, and then I need to ask the patient what symptoms you have, and then we take our routine brain, then we think of doing an angio or IM study. So that a good clinical history is must. I can't agree more.
thank you so much, Harsh. So with that, we go to the last lecture, and that is important lecture on the ENT surgeon's perspective. And
Dr. Jain, can you unshare your screen?
What do I do?
Yeah.
so Neeraj, can you help me out for sharing this talk?
Go ahead, sir. I'm here.
So
you can keep your video open first.
Okay, I've just kept the video open. Yeah.
And then come to share screen.
So I am not seeing this share
Come
screen.
to Zoom back. Come back to Zoom, where you can see us.
So I have the here.
Maybe your video is full screen. You can.
So let me sort it out. Hold on.
Okay.
Sir, what are you seeing in front of you? Just let me know.
Now I'm seeing the whole video panel now.
Yes, तो ठीक है. नीचे आपको share screen दिख रहा है?
हाँ, yes.
उस पे क्लिक कीजिए. Quick time आपको on करना पड़ेगा. Quick time on है आपका background में. उस पे quick time दिख रहा है?
हाँ, on है.
ठीक है. Quick time पे click कर दीजिए. Share sound पे click कर दीजिए.
हाँ, yeah, done.
And then click on share.
Yeah, thank you so much.
Good morning, all. I am thankful for inviting me for this symposia on vertigo, which is so common and often misdiagnosed. Thank you very much, Dr. Rajendra Chandak and all his team and the Orthopaedic Society. I shall start my presentation by giving you an overview of how to diagnose and manage vertigo, and then focus on a very unusual upcoming common cause of vertigo, that is vestibular migraine. Now, it's very common to say, and I'm sure all of you are accustomed to saying this, that any patient comes to you and say, I got cervical. Now, cervical spondylosis is overdiagnosed, and we all know that. But let me begin by giving you the real gist of my talk by beginning with just briefly saying why we become vertiginous or why we lose our balance. Now, the sensory inputs, then integration, and ultimately motor output, will result into balance. And let's analyze that. What happens first? There are three main inputs coming in, and they are the vestibular, which is equilibrium, which is spatial awareness, the sense of linear acceleration or deceleration. These all comes from the ear. The next is the vision, which is the most important input, which gives you a sense of location of various things, distance of various things, and also the verticality and horizontality as our eyes see it. Then, of course, the proprioception. I need not speak in front of the orthopedic people that all our joints, muscles, tendons, everything is supplied by proprioceptive fibers, which at any point of time will tell you where your hand is, where your head is, where your toe is. Now, all these inputs come into the brain via the cerebellum. The proprioception, however, goes directly to the brainstem, whereas the vision and the vestibular inputs are coming via the cerebellum and the cerebral cortex. Of course, they all talk to each other, and as a result of that, we end up getting three major reflexes which are responsible for maintenance or balance. The first is vestibular ocular reflex, which means that depending upon whatever the inputs are coming from our ear, your eyes quickly adjust to it. The second is that also adjusts the neck and the rest of the body posture muscles. So it is the input of all these three together will lead us to maintain our posture or maintain our balance. Now, there are two kinds of vertigo. We know the peripheral and the central. The peripheral vertigo arises from the end organs which are away from the brain, as it sounds. In my topic, I will concentrate on the vestibular apparatus. Most of these causes are fortunately benign and fairly easily treatable. Now, what are the features of peripheral vestibular causes of vertigo? Usually, the patient demonstrates nystagmus, that is, a jerky movement of the eye, and often to the opposite side, which is fairly common. And the nystagmus improves if it is suppressed by ocular fixation. That means when you open your eyes and fix on the object, you feel less vertiginous, but when you close your eyes and take away the ocular impulse, you become more vertiginous. They are also associated with vagal symptoms, particularly nausea and vomiting, and possibly occasionally sweating and bradycardia too. Now, how do you differentiate between the peripheral and the central? Fairly common that usually the nystagmus on the peripheral vertigo type is horizontal, or unusually it could be torsional, whereas central vertigo is purely vertical, which means the eyes just jump up and down. And this is fairly common in albinos or those who have obvious fairly central cause. The direction of the vertigo often is usually one-sided, but the central vertigo can change the direction either up, down, sideways, or even torsion. The central vertigo is not fatigable. That means it can keep on coming again and again and again, whereas the peripheral vertigo fatigues out, and therefore it's a very constant demonstrable site that you keep on stimulating the peripheral organ, you will get nystagmus or vertigo for a while, and then you stop getting it. Usually, there is not severe handicap in walking, whereas in the peripheral vertigo, whereas in central vertigo, there is a fairly severe handicap for walking. Vagal symptoms are usually absent or may not be there in the central cause, but common on the peripheral side. But the most important thing is there are associated audiological symptoms, and they are constant, which is tinnitus and loss of hearing. Now, there are certain other neurological features which are always absent in the peripheral vertigo, whereas the central vertigo will have other neurological features. Now, the commonest causes of peripheral vertigo I just enumerated here. Let us see them one by one. I listed them out here, but I will only restrict my talk because of paucity of time to benign paroxysmal positional vertigo, the manias, and the more interesting thing is nowadays the vestibular migraine. Now, BPPV is a fairly common cause, and it gives a very good response to the treatment, and that's why we should get that diagnosed correctly. It is caused by loose otoconia or the loose calcium crystals into the vestibular organ or the apparatus, the semicircular canal, usually the posterior semicircular canal, and they get moved and stimulate the hair cells, causing disproportionate signal coming from that particular canal, and therefore making you feel dizzy or imbalanced, or will give you a sense of false movement leading to vertigo. Now, what are the causes of benign paroxysmal positional vertigo? The commonest cause is canalolithiasis. That means the calcium crystal film which is there into the canals at the cupula usually get broken, and therefore the broken particle, which is a smaller one, moves at a faster speed than the main particle or the main sheet, and therefore causes these symptoms. Now, usually there is a history of trauma, but they may not be knowing that they are a trauma as a cause. The vertigo is induced every single time the patient moves his head, because that makes this small particulate dislocated organ move faster and therefore give rise to vertigo. Now, what is the disease progression? Usually is self-limiting. What happens is that broken calcium carbonate crystals will go into some part of the inner ear or the canal and lodge itself there and settle down. And the example I give is, if the water is full of mud, you shake the water, it moves for a long time, but after a little while, all the particulate matter in the water sets as a sediment at the bottom, and the water becomes clear. I mean, exactly something similar, although I tried to make it too simple. The associated conditions usually are those related to the head trauma, but often the manias and the vestibular neuritis can be present simultaneously. Difficult to diagnose in that case. Now, clinical features, these are brief, small spells of vertigo associated with rapid change of head position. This is absolutely constant. They do not last for a long time, sometimes maybe for a minute, but usually settles down. Remissions may not therefore come for months and months. The patient may have a few weeks of vertigo and then disappear and come back later when those calcium carbonate crystals come into a trickier part of the canal and start stimulating. Some patients, however, may have a chronic problem, and they are the worst patients to treat. Now, how do you diagnose? There are several tests, and the most sort of a common and most talked about is the Dick's Hallpike test, which has been there since my houseman days, but now there are more advanced tests available which can diagnose this condition more accurately. What's the purpose is that you tend to reproduce a symptom or a head position repeatedly so that you get a we get a demonstrable nystagmus. Now, there are certain diagnostic features that usually it doesn't come suddenly, it comes with a delay. It usually is downwards, doesn't go more than a minute. The direction is usually to the side, depends upon the affected canal, and usually the dizziness is subjective but can last a little longer. And often it is fatigable. That means if you do it few times, he stops getting dizzy. Now, what the treatment is? Now we know that the simulation is because of the calcium carbonate crystal. We can have some maneuvers to replace them into the position and therefore get away with it. There are several managements, A-place maneuver, C-mounts maneuver, Brand-Araf positional exercises, but often the patient learns to do them themselves, and therefore the medical treatment is often not necessary. There are so many drugs available in the market. Every time new drug keeps coming, I think they are not indicated or necessary. What you really require is physiotherapy or the various maneuvers. Surgical treatment can be a singular neurectomy, which is difficult to perform and often causes a lot of morbidity later on and associated risk involved with the facial nerve and the nerve, which is the cochlear nerve, which is hearing. Now, I just will run through this because this is not really the talk of in my mind, but there are various positions. You can quickly do it. They are available on the net for anybody. These are the various maneuvers, but these exercises are also very easily available to anybody from the various pharmaceutical company, and you can teach your patient. Pharmacotherapy is not really required except in a severe emergency. Now, manias. I'll just be very brief on mania because this is often misunderstood, and I can talk about this. This is my favorite hobby horse since my early days in otology, but just run through it. Now, it is an episodic vertigo lasting from minutes to hours, usually associated with low tone sensory hearing loss. With tinnitus, you get fullness, aura, and then you get nausea, vomiting. It is caused because of the head drops of the endoleaf and usually is unknown etiology. Now, as we say, the etiology is unknown, but the pathology that happens is known. It is the endolymphatic head drops. The onset of attacks is often sudden. Patient usually wakes up from the sleep feeling dizzy, and it can be preceded by an aura which can be multiple. With a vagal symptom, you may feel unwell, you may feel yawning, you may feel fullness in the ear, mild headache, some visual symptom, and then that is preceded by a full-blown attack of vertigo. Disease progression, very sadly, it takes a very long undulated course, may happen on the opposite side, and more often than not, the disease could be bilateral, and eventually you get a profound hearing loss in a few years' time. Now, management is medical and plus lifestyle. And usually the management will take me a long time to talk about, so controversial. You have got drugs of variety of types, even sometimes on opposite direction of their action, and yet they are found clinically helpful. But I'll just skip this part and come down straight onto the vestibular migraine, which is the meat of my talk. Now, usually it affects the person who already are established victims or sufferers of migraine. Usually occurs in the later part of disease, usually around 45 plus, although it is said to be in 30. In my observation, usually the headaches disappear and the vertigo sets in. This event turning occurs around about 40, 45. It is fairly uncommon cause of vertigo in middle ages, early adolescent, but in children, again, it can be fairly common. And then you get usually a autosomal dominance, and therefore you could say that the parents or mother, father, grandfather, somebody will have a history of a similar type. How does it start? We all know how the migraine starts. It is a vasospasm of the internal artery, subsequently starting from the anterior inferior cerebral artery, and then it gets on to the branches of the vestibular artery, and therefore we get into the vestibular dysfunction. Pretty straightforward. Now, what is it going to affect now? Once the vascularity of the inner ear, particularly the vascular supply to the vestibular apparatus, is affected by spasm, naturally you do expect to get all the vestibular symptoms. And the vestibular dysfunction will be mostly of vestibular ocular and the vestibular hypersensitivity. That means that a little movement will cause hypersensitive-like reaction, and therefore patients prefer to be absolutely steady. They don't like to move, and they don't like to see either, because this is one condition where they want to prefer and they like to sleep with eyes closed. See what I said about the earlier part into the benign paroxysmal mesopositional, or even in many years, that these patients prefer to keep their eyes open and fixed on the object. Here, they prefer to close their eyes and lie quietly. Exactly opposite. Headaches could be there or could not be there, depending upon the AICA involved. But if AICA is involved, you will expect to get some headaches too. The spatial disorientation is very marked. They don't know where they are. They feel woolly. They feel as if they're floating. There's some in the air or outer space, and that's a fairly distinguishing feature of vestibular migraine. Now, how do you diagnose? This is very difficult. It's by exclusion. You must say that there is at least something like 5 or 6 episodes of a similar description occurring and not lasting more than 5 to 10 minutes. So sometimes they can go on for days also. The history of previous migrainous headache is very important. And of course, you say that it is a probable that you do have a vestibular migraine by other symptoms that go on. And therefore, you have a normal audiometry, normal ear, no tinnitus, and episodes of migraine which are preceding to the headaches. And this is like a intuitive or diagnosis we do by experience. Now, probable vestibular migraine, because sometimes you don't know whether it's a vestibular migraine or not. Usually, you will say that the migrainous symptoms or preceding migrainous symptom, and the other thing is the sort of a therapeutic trial. You put them on anti-migraine treatment, and most of them recover very, very well. And there is at least a 50% reduction in the severity and the frequency of the attack. As I said, vestibular migraine is a clinical diagnosis. There are neither radiological, nor biochemical, nor even almost all fancy investigation at your armamentarium to diagnose this condition. So it is an intuitive diagnosis, number one. The only differential diagnosis comes is Meniere's. But Meniere's can be differentiated very quickly by the episodes, by the description of the vertigo, the tinnitus, and the low tone hearing loss. There might be other symptoms which are already there in all the things, but the most important symptom which differentiates all other vertigo episodes from the vestibular migraine is photophobia and phonophobia. They are so remarkably present and also absent in other conditions. The vertigo usually precedes by aura, as all the vestibular, all the migrainous episodes are preceded by the aura. They may get a similar aura as they used to get when they got the headaches. Or they may have a slight change, but it's always an aura. And the aura could be blurring of vision, floating sensation, feeling tired, yawning also occasionally. And there will be always a trigger factor. Like there's a trigger factor for the headache migraine. And the trigger factor is something which patient will volunteer if you have time enough to listen to them. Now, management, lifestyle. I deliberately put that as a big blank slide because easy to say, difficult to do. How often people will advise you, oh, please change your eating habits, doctor. You are too hectic. You should not not sleep or not rest and eat and then take. How many of you follow these advices? How many of you are able to follow these advices? So it is very easy said than done. But they can keep a diary. This helps. Keep a diet diary, keep a vertigo diary, and then figure out what are their trigger factors. Trigger factors could be caffeine, preservatives, light, bright light, blinking light, cheese, chocolates, alcohol, pills, and strong smells. They'll always tell you that does it, doctor. And if it says so, simply saying avoid the trigger. Treatment with triptans, which is the next line of action. And we all know that there are various kinds of triptans available, but the most easily available triptans and use, I'll come in a minute, but then the other line of action is antiemetics and vestibular suppressants like promethazine, diphenhydramine, and meclizine. Now let's see what the triptans are available with us. But choosing right triptans is essential because depend upon the patient's activity, patient's need, frequency, severity, and therefore alertness required on his job. All these factors matter. And then there are fast-acting triptans, slow-acting triptans, long-acting triptans. Choose your patient and choose your triptan. Now, prophylactic treatment is something very important. The first thing I said earlier, and it is also said often but not enough, is change in lifestyle and figuring out the trigger factor. But the next come is getting on to some vasodilators. I prefer beta blockers so that you prevent the spasm to come. And it is very important that any small dose of beta blockers per day can be both diagnostic as well as therapeutic. Prophylactic, we just made, non-pharmacological measures, sleep hygiene, diet, is said so many times, and it's correctly said also. I'm not saying I'm overdoing it, but it is easy said than done, but it does work wonders. Vestibular rehabilitation. In fluctuating disorders like Meniere's, neuronitis, vascular migraine, vestibular migraine, all the vestibular rehabilitation exercises and therapies do work, but their importance is not so established in case particularly of vestibular migraine. Physiotherapy helps, But again, as I said, the cause is so different, the pathophysiology is so different that the physiotherapy doesn't offer much. Pharmacological prophylaxis we just talked about. Now, one of the things, when do I start my patients on either triptans or on vasodilators? The real guidelines are how frequently does he get an attack? Supposing the calcium channel blockers such as Sibelium, which works wonder, you want to try and start that, but when do I start it? Because they have their own side reaction. There is weight gain with it, there is sleepiness with it, there is loss of alertness in people who are doing, say, surgeons or people who are involved in driving or mechanical skills, which are important. Then probably the indication would be one, there should be documented 3 or more attacks per month. These attacks should be so bad that they are incapacitating and they impair their normal activity. And the third is they cannot tolerate the abortive therapy or the other medicine. And the last, of course, is psychology. If they're too disturbed, please don't hesitate to start the prophylactic pharmacotherapy. Now, beta blockers I mentioned is propranolol and metoprolol. Choose one which is dependent upon, say, for example, we all know that metoprolol will have a side effect like depression, hypotension, postural fatigue, nightmares, and occasionally bronchospasm. Calcium channel blockers I just mentioned are fairly safe. Flunarizine, verapamil, antidepressant, tricyclic, and they are useful. We just talked about triptans, but the second line of drug should include valproic acid and methotrexate acid. Fortunately, very rarely will you require the second line. Now, the new treatment inside, if you can cause vasodilatation, if you can cause vagal suppression, there are now implantable devices which are available, which can be stimulated from outside to get this effect. I mean, this is far in future. I think it will be a fairly long while, and maybe I will retire before this comes into India, into practice. Now, concluding, vestibular migraine is diagnosed only from the history and a high index of suspicion. There are no laboratory tests, and they have very little role in diagnosing vestibular migraine, except rule out other pathologies. Second, the recurrent attacks, the prophylactic treatment does help and prevents the severity and the frequency of the symptom. And the traditional migraine therapy, both abortive prophylaxis, have a great role or great therapeutic as well as diagnostic role in management of vestibular migraine. Now, I run like a marathon race through this talk. It's a very difficult subject. I'm sure all other specialties will chip in, but no one specialty probably would be adequate enough to treat a patient, which is a classical. A 70-year-old lady has a cataract, can't see, has a knee problem, has a little bit of Parkinson's symptom. She walks through the clinic and says, "Doc, do something. I am very, very dizzy." Now, for those kind of patients, I think what is required is a little bit of luck, patience, and more than that, you must have the empathy to understand that your patients are really bad and treat as best as you can. I wish this conference a great luck. I thank again Dr. Rajendra Chandak for inviting me to talk to you. And in case there are questions, I'm sure there will be ample opportunity to answer on my behalf and on everybody's behalf. Thank you all very much once again. Have a good Sunday.
Thank you so much.
Bye-bye.
Sir. So, Sangeet, again, back to square one. What do we do when we see a patient of vertigo? And a lot of them are there in the...
Yeah, the disease is symptomatic.
Yeah.
Where diagnosis is by elimination. And once you have diagnosed them, probably there are very few investigations which are point blank and which can help us. And it is quite significant, like a patient who's in the office going, he cannot live with that giddiness. It is very disturbing for anybody. But probably we had a good insight today on the various aspects which will help us in at least diagnosing these various conditions which we saw, or probably we will be referring them now to an appropriate specialist having diagnosed them in our practice, at least they will not go anywhere else, or like they will not be shifted from one to second to third specialist. At least we can direct them properly to a specialty where the origin can be found out of his vertigo.
Yeah, and with that, a good clinical examination, coming to a conclusion, appropriate investigation, and managing them appropriately. I think that is the take home for us, so that we can manage this patient effectively. Thank you everyone for joining. If there are any questions in the chat box, that is fine. Otherwise, we'll wind up this webinar. Thank you very much, Sangeet, for being there.
And on behalf of MOA, we have to thank.
Yeah. So, and from behalf of Dr. Gadegone, who is busy with the election EC meeting, I think we thank MOA office bearers for allowing us to give this opportunity to hold this webinar on an important topic, though a big topic, on vertigo. We thank our president, Dr. Wasudeo Gadegone, and Dr. Karne, the secretary of MOA, to give us opportunity. Myself and Dr. Sangeet Gawhale have been given this opportunity to hold the Veteran Surgeons Forum. And the next month we'll be announcing in advance what is the topic for the next month. Thank you very much, Sangeet. Thanks everyone for joining in, and thanks all the delegates for your participation. Thank you so much.
Thank you so much. Bye.
I think, Neeraj, we can
stop recording.
Yeah.
No, the recording is still on.
We'll have to stop.
Yeah, we'll have to leave, sir, because the recording is still on.
Yeah. I think we'll message them. Neeraj, if you can stop.
Ashok, Supratim, Ashok, Neeraj, can you stop recording?
I'll message them.
We can leave, sir. We can talk.